Good afternoon and welcome to Time is Brain, Understanding Stroke, hosted by Tallahassee Memorial Healthcare. I'm Trish Higgins-Karowski and I'll be the moderator for today's program. Joining us is Dr. Matthew Lawson. He's an endovascular neurosurgeon at Tallahassee Neurological Clinic, and he's also the stroke medical director at TMH. So if anybody has answers to your questions about stroke, it's Dr. Lawson. Dr. Lawson, thank you for joining us today.
Thank you very much for having me.
In this hour, we're going to be talking about how to prevent stroke, if that's possible, the signs and symptoms of stroke, and also the treatment options that are available at Tallahassee Memorial Healthcare, which is a comprehensive stroke center versus a primary stroke center. And we'll be explaining the difference between those two throughout the course of the program. Also, I know that some of you submitted questions ahead of time, and I will be sharing those questions with Dr. Lawson as we go through the program. But if you have any additional questions, feel free to use the Q&A chat feature in Zoom, and I'll be monitoring that, and I will try to get you answers to those questions in real time as we go along. And we've got a lot to cover, so let's get going. Dr. Lawson, let's start off real broad to begin with. And I'd like for you to explain what exactly is happening when a person is having a stroke. What's going on in their brain?
Well, so first of all, a stroke is an emergency. It's a brain attack. It's just as serious as a heart attack, except for it's happening to the brain. The most common kind of stroke is something called an ischemic stroke. And you can think of that literally as the blood vessels that are taking blood to the brain become blocked with a blood clot. And so your brain is not getting blood flow or oxygen. And so it's not working, and you have neurologic symptoms as a result of that.
When you say it's not working, the brain cells are dying. Is that correct?
Exactly. So when you have a blood vessel that's blocked off in the brain and you don't have blood or oxygen being delivered to that area, those neurons start to die. After just a few minutes of not having enough oxygen, neurons, or the cells in the brain that are doing all the hard work, they start to die. And really, so the goal of any stroke treatment is to restore normal blood flow, restore normal oxygen delivery to those brain cells.
And hence the need for quick response.
Exactly. Time is brain. So the longer you go without enough blood flow and oxygen to your brain, the more and more neurons die. So the quicker we can intervene and change that and restore normal blood flow, the better it is for that patient.
So when we talk about that time frame, are we talking minutes? Are we talking hours? If I see someone who looks like I think they might be having a stroke, this is not the time to say, well, we'll see how you feel in about an hour or so.
No, absolutely not. Okay. Minutes, ideally, we want to intervene ASAP. And, if you see someone having a stroke, that's not the time to lay down and let's see if this passes, or the last time this passed in 20 minutes, we'll just give it some time. That's not the right thing to do. The right thing to do is to call 911 and seek immediate medical attention, because a stroke is an emergency. It's a life-threatening emergency, and time is brain.
There are two, if I understand this correctly, there are two different kinds of strokes, correct?
So there's two major types of stroke. Ischemic stroke, so that's like 85%, approximately 85% of all strokes are ischemic strokes. And that's when a blood vessel is blocked and therefore blood flow and oxygen aren't being delivered to a certain part of the brain. The other type of stroke is hemorrhagic stroke. And so that's related to bleeding. That's when a blood vessel ruptures and there's bleeding within the brain causing things not to work. And that's about 15% of strokes.
I always assumed that strokes kind of went along with the aging process. Is that an accurate assumption?
Well, it is to some degree. Strokes definitely increase with age, particularly over age 55. And there's about 800,000 strokes a year in the United States, but a third of those are in patients under age 65.
Really?
Yeah, and so that is a big deal because those are the breadwinners of their family. Those are head of household type people that usually have jobs and they're taking care of others. They're functional individuals, and that's why stroke is the leading cause of disability in the United States.
Okay, I want to get into what causes them, but before we do, I would like for you to describe to us or show us what it is a person should be looking for if someone looks like they're off, okay? And you don't know if they're having a stroke or what should we be looking for?
So there's a couple of different sort of mnemonics that people use when they're thinking about stroke symptoms. There's be fast, there's fast. I actually like fast because it's easier for me to remember. Fast stands for face, arm, speech, and time. And so that's, facial drooping or facial asymmetry, the arm weakness, abnormalities in speech. And if you see someone that's having any of those symptoms or all of those symptoms, those are, things where you really need to think, I think this person's having a stroke. Let's call 911.
Okay, well, we're going to have to learn those. We're going to have to memorize them and keep them at the front of our brains then. Talk about when you say that someone they need to get to the hospital right away. This is not maybe we should, wait, or we don't want to overreact or whatever. Overreact, get them to the hospital. What is the difference between bringing them to TMH, which is a comprehensive stroke center, or going to a primary stroke center, which is, I guess, what other hospitals are? Is that correct?
Right. So most hospitals that treat stroke are actually primary stroke centers. And really, there's nothing bad about a primary stroke center. If you're having a stroke, you need to get to a stroke center. Primary stroke centers offer sort of the basic evaluation and treatment for patients having strokes. So they will see them in the emergency department. They're able to give TPA, which is a medication that sort of dissolves blood clots. So that's a treatment for ischemic stroke. Remember, 85% of strokes are ischemic strokes. That's blood vessels blocked off, usually with blood clot. So we treat those with TPA, which is a medication that helps dissolve blood clot. So primary stroke centers have the ability to do that. Often their neurologists aren't on site. There's teleneurology. And so the doctor seeing you may not be physically there. And that's as opposed to a comprehensive stroke center. So there are much fewer comprehensive stroke centers in the United States, and I'm proud to say that TMH is one of them. And what does a comprehensive stroke center offer? It's really the next level of care. And so we offer rapid treatment and evaluation for patients. Obviously, we give TPA as well because patients come here and they meet criteria for TPA. But then the next step, what's the next step? Well, more and more a procedure called thrombectomy is important for stroke treatment. And a thrombectomy is a procedure where we go within the blood vessels. We navigate small catheters from inside the arteries all the way up into the head using X-ray guidance. And we're able to remove these blockages or blood clots that are starving the brain of oxygen. And so comprehensive stroke centers, they offer that next level of treatment and also more comprehensive care in general.
You have a video of that, don't you? Of the thrombectomy?
Yes,
Can
I
you
do.
show that
Sure.
to us? Thanks.
We'll just pull that up here. Let me share my screen
Okay.
if I can. Yeah.
I think it's helpful to have a visual so we can see what's going on, because to me, is there pain when you have a stroke? Is that an indicator?
So pain really isn't part of it. Let's see if this will play. So this is just an animation
Mhm.
of what happens when we're doing a thrombectomy. And so you can see that there's a blockage inside of an artery, and that's literally what's happening when you have a stroke. And we navigate some catheters all the way up into the brain using X-ray guidance. And so these are inside the blood vessel. We do this over wires. I'm sorry that it's freezing up. I'm not sure
That's
what's going on
okay.
with that.
It's having a stroke.
I'm not the
Maybe.
technical guy.
Trust me, neither am I.
So we navigate these catheters over the micro wire all the way up to the level where the blood vessel is blocked. And then we use what's called an aspiration catheter. And I'll see if I can pause this thing right there. But the aspiration catheter, which is sort of highlighted in gold here, it's a pretty large catheter, and we apply high suction to that. And so that is what actually sucks out the clot.
Wow. So you vacuum
So
that clot right out of the
yeah, we
brain?
engage the clot with the catheter, apply suction, and it just aspirates right out. And so that restores normal blood flow to their brain. And that is how most thrombectomies are done today. So there's other procedures that we can do when we're doing a thrombectomy, other devices, something called a stent retriever, which also works well. But that aspiration technique is sort of the latest and greatest, and that's how most thrombectomies are done at TMH here today.
So if someone comes in fairly quickly after the stroke has occurred, and you determine that they need to have a thrombectomy, and you do that, what are the chances that a person having a stroke will be able to recover, functionality and all of that, pretty much?
So a lot of that depends on how long have they been having their stroke. So sometimes we'll have patients, they are sitting there at dinner and they have their stroke. It's in front of a bunch of people. They call 911 within a minute. They get to the hospital rapidly. We figure out what's going on, and their thrombectomy is done within 90 minutes of their stroke starting. If that happens, their probability of getting better is pretty high. On the flip side, sometimes we'll have patients, they've had their stroke sometime in the middle of the night. We don't really know when. They come in hours after it's happened. We still do a thrombectomy. They may not have as good of a result. Literally, time is brain, and this is an emergency we want to do ASAP. All that said, sometimes patients will have recovery, within hours after you remove a thrombus, and sometimes it takes a whole lot longer. The recovery window for stroke patients, though, that is really measured in months, 6 to 12 months. So someone who's had a stroke and they have weakness or problems with speech, those patients have the potential to improve, slowly with therapy over many, many months.
Okay, but there is the potential for improvement, which gives us hope. I want to go to a viewer question here real quick that applies to this. Is there any testing to tell if you've had a stroke in the past?
So we can see stroke on MRI and sometimes CAT scan. So chronic strokes appear differently on those imaging studies. So when someone we think is having the stroke, we'll get an MRI, and the MRI can show acute stroke, stroke that's happened in the very recent past, the last day or so. And that shows that very well. But we can also see old strokes on those types of studies as well. So the best test would be an MRI.
Let me go to another one here. How dangerous are TIAs, mini strokes, and is it true that they lead to major strokes?
So TIAs, and a lot of people refer to those as mini strokes. Those are stroke-like symptoms that come on and then get better. And so that's the scenario where, hey, my spouse had a drooping face for 20 minutes and their speech was all garbled, but then they went back to normal, so we didn't do anything. Those are very serious. Those are sort of the smoking gun, if you will. That's the warning sign that, hey, there's something going on here, and you had what's called transient ischemia. You had a brief period of time where you didn't have normal blood flow in your brain and you had neurological symptoms. So those should be taken very seriously, and they definitely require evaluation.
Okay, good information. Let's talk about the risk factors for stroke. Is there a genetic component to it? Who's at risk of developing a stroke?
So there are genetic components, but the major risk factors aren't. They're sort of, what we do every day. So, and they're similar to the risk factors for other vascular disease and heart disease. Okay, so things like smoking and tobacco use is a major risk factor. Blood pressure or hypertension, uncontrolled diabetes, elevated cholesterol, obesity, pre-existing heart disease or heart valve disease. Those are all big risk factors for stroke.
I want to answer this quick question here that just came in. Is Bell's palsy related to stroke?
So no, Bell's palsy is not related to stroke, but it sort of mimics stroke. That's paralysis of the face. It's not a stroke symptom. And sometimes it's hard to tell, especially when it suddenly happens. Is someone having a stroke, or is this Bell's palsy? I would say go to the hospital and let us figure it out.
Right. Leave it to the experts if you're in doubt. You and I have talked before a little bit about this, but you mentioned to me once a stroke belt, and I wonder if you would explain to our viewers what that means.
Yeah, sure. The stroke belt is really the southeastern United States. And so the southeastern United States has a higher stroke rate than other parts of the country. And it's unclear exactly why that is, but the Southeast is definitely leading, and this isn't a good way of leading like
right.
we do with SEC football. But unfortunately, the southeastern United States, yeah, sorry.
Yeah.
The southeastern United States definitely has a higher risk of stroke, and that may be related to higher rates of obesity, or maybe socioeconomic status, because there are other risk factors for stroke too, and there are some racial discrepancies with stroke, which are unfortunate but magnified in the Southeast. So the rate of stroke in African American populations and Hispanic populations is definitely higher than white, and so I think a lot of that kind of comes together, and the Southeast has a higher stroke rate, and they call that the stroke belt.
Okay. Is there a gender? Do women versus men? Is there any difference there?
Not as much as you think. So, unfortunately,
I've lost your audio there, Doctor. I've lost Dr. Lawson's audio. Is there? I'm not hearing you. Are you there? I don't know if you can hear me, but I seem to have lost Dr. Lawson's audio.
All right, can you hear me now?
I can hear you now. I can hear you now. I'm not sure what happened there.
Can you just tell me the question again?
Yeah, I was just wondering if there was any difference in men versus women as far as stroke, the possibility of developing a stroke.
Stroke doesn't discriminate by gender. There are slightly higher risks of ruptured aneurysms, which is a type of stroke in females compared to males. But no.
Okay. How about stress? Does stress cause strokes?
So that's a common question that we get, and I don't think so. Otherwise, my partners and I would all have had strokes by now. But stress itself, we don't think contributes to stroke. However, Some behaviors that go along with stress, like not eating right, having high blood pressure, those can certainly affect your risk of stroke. But stress by itself, no, that's not a major risk factor.
When someone comes to you for treatment, is there a particular type of diet, or, I mean, what do you tell people to recover from or to prevent another stroke? What do you tell them?
So in general, we want everyone who's come through the stroke center and had a TIA or stroke to be on a heart healthy diet. So that's a diet low in saturated fats and cholesterol. And unfortunately, a lot of times patients don't have the greatest diet. We all eat too much fast food, and times at a crunch, and changing that sort of habit. One, it's hard to do, but it definitely will improve their chances of not having a stroke in the future. So dietary changes are hard to do, but I think necessary if you've had a stroke or even are at risk for one.
And exercise, I'm guessing exercise has to play a part in this.
Absolutely. So diet, exercise, not smoking, blood pressure control, those are all major things that help reduce the risk of stroke.
So if you don't want to have a heart attack and you don't want to have a stroke, it's basically the same sort of, you got to look at your lifestyle, because those are the things that are going to keep you from showing up in your clinic.
Absolutely. So those lifestyle changes or lifestyle things, that they contribute to all sorts of vascular disease. So not just stroke, heart attack, but peripheral vascular disease, that sort of stuff. These things are all related.
Can you talk a little bit about the long-term consequences of a stroke after a person's had a stroke, and say they've gotten to you in time and you've been able to treat them either with the medication or the devices or whatever, but that's not the end of stroke for that person, right?
So no, that's not the end at all. So first of all, stroke is still the 5th leading cause of death in the United States. Okay, so there's still certainly a chance of passing away from the stroke. But it's the leading cause of disability. And so when someone has a stroke, they have neurological impairment that often lasts the rest of their life. And yes, they can improve through rehab and that type of thing. And oftentimes, like I mentioned earlier, improvement can last a year. But many patients have long-term impairment related to stroke. That's why it's the #1 cause of disability. The other factor is something caused their stroke, okay? And that may be atrial fibrillation or some other type of heart disease, and maybe carotid disease, maybe uncontrolled diabetes. So whatever we determine was, the likely cause of that stroke, that's going to require treatment in the future. That doesn't change the fact that that individual had a stroke, but hopefully it reduces their risk of having a second one in the future. And that's a big deal, because of the roughly 800,000 strokes a year in the United States, about 200,000 of them are second strokes. So
Wow.
someone who's already had a stroke who has another.
I also, we've had several in my family, and I noticed that there was, after my father had a stroke, as a matter of fact, depression and kind of a change in his personality. Can you address those things?
Yeah, absolutely. So depression is a very common feature in patients who survive stroke. In fact, it's probably underdiagnosed. And there's a big push now to identify and treat stroke survivors with depression symptoms. It's one of the things we look at and track in our stroke populations. So it's common and sort of expected. So I think the important thing there is to identify when somebody has depression after stroke and make sure that we get them on treatment. And that can include antidepressants, but also psychiatry and psychology. I think the other part of your question was regarding personality changes. And so, yeah, personality changes go along with stroke as well. And so when you think about it, you know, stroke is part of the brain has died, part of the brain isn't functioning properly. And there are major parts of our brain that define who we are, you know, what we're like, what our personality's like. And when those areas are injured or die in a stroke, can cause personality changes for sure.
And those are generally permanent?
They can be, yes.
Wow. Okay, I have another question here from one of our viewers. What is the exam for TIA?
What is the exam for TIA?
Yeah.
So it's actually very similar to what you get if we think you had a stroke. And TIA symptoms could improve up to 24 hours. So when you're in the ER, it's still not always apparent if you've had a stroke or if you're having a TIA that's going to be better in an hour. You know, we don't always know. And so in general, when you come into the emergency department at TMH with stroke symptoms, you very rapidly get 3 tests. And that's a non-contrast head CT, that's a CT angiogram of the head and neck. And so that study looks at the blood vessels of the head and neck, you know, specifically looking for large blood vessels that are blocked. Those are the patients who get a thrombectomy. And then the third test they get is something called a CT perfusion test, which is a study to evaluate brain perfusion or brain blood flow in the setting of their stroke. And that helps us determine if someone's a candidate for a thrombectomy. But to answer your question, the workup for TIA, if you come in having TIA symptoms, you'll get those 3 studies. And if they're negative, which they often are in TIA, you'd be admitted to the hospital. We usually would do an MRI to confirm was there a stroke or not. And then other tests for common causes of stroke. So blood work to look for diabetes and check cholesterol levels, things like that. An electrocardiogram to evaluate the heart rhythm. An echocardiogram to look at the heart and look at the valves and make sure there's no issues there. So basically a workup would include looking at those things to determine, okay, is there some smoking gun here that could have caused this person's TIA symptom?
Is it possible to have a stroke and not know it?
Yeah, it is possible to have a stroke and not know it. You know, some areas of the brain, you can have a small stroke in certain areas and just not recognize that there's anything wrong. So if you think about it, that mnemonic I mentioned earlier, FAST, it's facial weakness, you know, arm weakness, speech problems, and then time, like get to the hospital fast. So you can have stroke symptoms that don't involve your speech or your arm or your face. Sometimes patients will have strokes in what's called the posterior circulation, which is the cerebellum and brainstem, and those have much more vague symptoms that are harder to detect, harder for us to evaluate as doctors, but also harder for lay people to realize, hey, I'm having a stroke.
Mm-hmm. Okay, I've got another one, and I hope I get this right. I'm going to read this right off the chat. Diagnosed with an amaurosis, something, but carotid echogram was less than 15% plaque. What other things can cause this?
You know, so amaurosis is transient visual obscuration that classically is related to carotid artery stenosis. And so the first artery off the internal carotid artery is actually the ophthalmic artery, which takes blood to your eye. And so when patients have blockages or carotid artery disease and little areas of plaque break off and go downstream and cause stroke, sometimes the first thing that go down is the artery to the eye. And so patients have these transient periods where they lose vision in the eye. And that you can think of that as like a TIA to your eyeball, okay? So number one, when someone has that happen, it's important to evaluate for carotid disease. And it sounds like whoever asked that question, that's been done. Usually we don't evaluate with a carotid ultrasound. An ultrasound only looks at the carotid bifurcation, which is a relatively small part of the carotid. Now we'll usually use CT angiography, which looks at the entire carotid artery, which goes from your chest up to the base of the skull. So it's a more complete evaluation of the carotid. But then if that's all negative, the other important thing to see is your eye doctor, because you can have visual changes
Right.
because you have some other problem
Other
with your eye that's not related to stroke.
Okay, another good question just came in. Are there regions of the brain that are more susceptible to impact from stroke?
So every area of your brain is susceptible to stroke. And so stroke is literally blood flow and oxygen is stopped to part of the brain. So whatever part of the brain that is, that part doesn't work anymore. Okay, and that's sort of the thinking of stroke from a very basic level. There are common strokes in the middle cerebral artery distribution. Why is that? Well, it's the biggest branch off the internal carotid artery as it enters the head. And so the middle cerebral artery takes a large amount of blood flow to a large area of brain. That also is the major motor area.
I was going to say, now, what does that affect in our brain?
So on the left side, it can affect speech and motor activities. And on the right side, it goes to major motor areas as well. And so since it's such a large vascular territory, statistically, if some clot breaks off from your heart and travels to your brain, there's a high likelihood that it ends up in that territory. And that causes potentially facial weakness, arm weakness, speech problems, which is kind of the basis for the whole mnemonic.
Fast, yes.
Yeah.
Viewer question, should I take aspirin? If so, when? I don't know, can you answer that?
Probably not for that person. I don't know, are there attorneys on the? No,
yeah, really.
That's a joke, sorry. So in general, if you think you're having a stroke, what you really need to do is call 911 and get to the hospital, and you might be put on aspirin. Should any individual be on aspirin? That's really something to talk to your doctor about. But in patients who have come in who have had a stroke or have had a TIA, putting them on aspirin, blood pressure medicine, cholesterol medicine, those are all sort of the standard treatments. So somebody who's had a TIA almost certainly is going to be on aspirin or some other, blood thinner type medicine. Aspirin's not really a blood thinner, it's an antiplatelet medicine, but they're going to be on something to help reduce their risk of future stroke. So aspirin plays a very important role in reducing your future risk of stroke.
Another great question here. If I've had a stroke, is it safe to get the COVID vaccine?
Yes.
Really?
It's definitely safe to get the COVID vaccine. We haven't seen a ton of this in our local community here, but we definitely see thrombotic events, including stroke and DVT and PE in patients who have had COVID. And so COVID sort of increases your risk of having thrombotic events, including stroke, and can increase your stroke risk in the acute setting. And so getting COVID definitely puts you at risk for having a stroke, increases that. And it's certainly advisable to get the COVID vaccine. If you've had a stroke or you're at risk for a stroke, you need to get vaccinated. I'd also say we do have some COVID-related trials going on, like NIH-sponsored trials looking at thrombotic risk in patients who've had COVID and then their outpatient recovery. If we put them on particular blood thinners, do we reduce their risk of stroke in the future? Do we reduce their risk of DVT or PE? Things like that. So there are ongoing investigations to look at stroke risk in COVID patients, but we don't have the results just yet. That'll be a little bit.
But bottom line, get the vaccine?
There are very few reasons to not get a COVID vaccine. Stroke certainly isn't one of them.
Okay, good. We've got some great questions coming in, and I'm just going to try to get through all of them. Okay. In terms of getting to the hospital, you mentioned call 911. what is getting driven to the hospital? What, if you thought that was faster, would it make a difference? Does EMT treatment outweigh benefit of getting to the hospital faster?
So I guess if you live right down the street, that's certainly an option. The benefit of EMT treatment is, number one, a medical professional shows up there. Sometimes patients have other problems going on that you need an EMT to help take care of. We have very good relationships with our local EMT groups, okay? And, TMH serves, I think it's like 17 different counties, and we have relationships with all of those EMT groups. But if they're bringing a patient into the hospital with stroke symptoms, they call ahead and a stroke alert is paged out, and we are expecting them to arrive, and one of our nurse practitioners is waiting for them in the emergency department. And so having a stroke alert paged certainly helps expedite that whole process. If you're right down the street and you don't want to wait for EMS and you think you can get your loved one to the hospital, I don't think that that's advisable. I think, 911, that's what it's for. It's for stroke and heart attacks and emergencies. If someone's having an emergency, call 911. I think that's the right thing to do.
I think that's great advice. Okay, does having a DVT/PE in the past increase my risk of stroke?
So maybe. Some patients have what's called a PFO, or patent foramen ovale. You can think of that as a hole or a defect in the heart where blood can cross from one side to the other. So if that's present, having had a DVT in the past could cause a stroke or put you at risk for having a stroke. But in general, that's venous related clots or thrombosis. Those are different problems. Those are problems you need to see my wife for, who's a hematologist here.
Nice plug there. Good work. Okay. If you think, this is another viewer question, if you think someone may have had TIA or strokes in the past year to year and a half and apparently not gone to the hospital, should they be checked out? Only symptom that's recognizable to others is for a very short time, up to 30 minutes, cannot remember how to do something that they do every day. Also has vertigo and falls for no reason. Are these signs of stroke?
They could be. And so I guess the first part of the question was, if you think somebody's had a stroke in the past, should you seek treatment? Yes, the answer is yes. That you don't need to go to the ER, okay? If someone had a symptom in the remote past, but you definitely need to see their doctor, and they may need to, be referred to a neurologist or endovascular neurosurgeon. But that workup can start with the primary care doctor. What was the second part of the question?
The second part is they cannot remember how to do certain things that they do every day, also has vertigo and falls for no apparent reason. Are these signs of stroke?
So the vertigo and falls could be. One of the other mnemonics for stroke, like I mentioned, I like fast, but there's one B fast. B fast, the B stands for balance. And so balance problems or coordination problems can be signs of stroke. But there's also a whole lot of other neurological conditions that could cause not remembering how to do things, or trouble with your balance, or, so not every neurological symptom is stroke. And so, if someone's having those things, I think it's important to start that workup with your primary care doctor, and then they may refer to a neurologist, from there.
I've got one that, and I'm not sure if you can even answer this one, but I'll throw it out there. Dr. Lawson, no pressure. Is it unusual for a doctor to prescribe Dilantin for a person who has had brain damage?
So Dilantin is a seizure medication. So we don't specifically prescribe that for patients having strokes. You would be on Dilantin if you have a seizure disorder. And you could have a seizure disorder from stroke, certainly, or other brain injuries like head trauma or, bleeding in the brain or brain surgery. So there's a number of reasons why somebody might be on Dilantin. It's pretty uncommon to have a stroke patient end up on Dilantin though.
Okay. We're running out of, we need to start wrapping it up here, but I wanted to ask you, can you have a mild stroke like you can have a mild heart attack, mild to severe? Is it on a spectrum?
Absolutely. So there's something called the NIH stroke score, which sort of quantifies the severity of stroke. And yes, you can have a mild stroke where your symptoms are just maybe some tingling in your arm or your hand, or maybe some subtle weakness in one of your extremities. It could be very mild, almost not noticeable.
Okay, now you're terrifying me because, I mean, who doesn't have tingling in their hand every once in a while, right?
Right. Yeah, yes, I'm sure your tingling is from your carpal tunnel syndrome.
Good point. Okay. All right.
Well,
But I mean, some of these, I can see people thinking, oh my gosh, my arm is tingled, whatever these symptoms are.
I think, if you have had some arm tingling, talk to your doctor.
Okay.
If you have facial drooping, arm weakness, and you can't speak, that's call 911.
No, okay. All right. I
So-
wanted to go over that because I think that's really important. If you only have one of those, still call 911.
Yeah.
If someone's face is drooping and you look at them or whatever, and it's just that, but they're still strong, it's still a
yes.
911.
Yeah, that's still a 911. So if somebody all of a sudden half their face is not working and they have facial droop or their face is paralyzed, that's a warning sign for stroke that needs to be evaluated for sure. That's a get to the hospital right away type
Same
problem.
thing with the slurred speech or the weakness,
Absolutely.
confusion. Okay. Don't mess around. It's not going to go away. You need to get in and get evaluated right away.
Absolutely. And, I think the important thing to remember is time is brain. The number one reason that you have a stroke and we can't do anything about it is the patient presented too late. Okay. And so that's still the main reason we can't give TPA to patients. And so the standard treatment is, first line is TPA, that medicine that dissolves blood clots.
Mhm.
We only give that really up to 4.5 hours after the onset of symptoms. Okay. So that time is critical. We need to know when this started and make sure you're within 4.5 hours. You show up at 5 hours, you're not a candidate anymore, even if we think you're having a stroke. Right?
Really?
We can't give that medication.
Wow.
And then the other procedures that we do, thrombectomy, the window is larger. We can do those out in certain cases to 24 hours. But that depends on whether or not the brain is alive and the perfusion tests and other advanced imaging, that's performed at a comprehensive stroke center. But it doesn't guarantee that you're a candidate 16 hours in. So if someone's having stroke symptoms, you need to seek immediate medical attention. If you go from normal to now my face is drooping and my speech is garbled, that's a go to the hospital type problem.
I think you just answered this, but we're about out of time here. And I was going to ask you, if people take only one thing away from this discussion today, what would you want that to be?
That time is brain. And that if someone is having stroke symptoms, that is not the time to lay down and see if it gets better. It's call 911 and get to the hospital, preferably a comprehensive stroke center. But depending on where you are, you need to get to the hospital, call 911.
Great advice. Dr. Lawson, thank you so much for your time today and your expertise. We really appreciate it.
Thank you very much. It was a pleasure being here.
And thank you to all our viewers today for all of your insightful questions and for watching and staying with us. If you are interested in learning more about stroke treatment and stroke services available at TMH, please visit tmh.org/stroke. We hope you have a great rest of your day. Take care.